Okay, I hope everybody can see everything. Vikram, can you see me? I can see you. You can see the screen? Perfect. So everybody can see everything. Perfect. Okay, cool. Let's start off without further ado. First of all, let me say that we're very glad to have everyone here. Whoever's participating so far, I hope you guys learn a lot because there has been a decent effort being put into this. My name is Karthik Bhagat. I serve as the president to the alumni chapter at GIMSOC. I'm joined by Vikram. He is the vice president and my co-pilot for years now. And hopefully, and the overall motive behind this webinar is that I hope everybody gets to learn tons and tons because whether you're in your first year or in your sixth year, sooner or later you are going to be asked to take a very detailed history. And if you are able to follow a particular format, the one that we worked on, the one that's usually followed all around the world, I think all your attendings, your consultants, your specialists are going to be very, very pleased with you. So let's start off. Also, if you have any questions, we will be addressing them towards the end of the webinar after our two case simulations. So you can use the chat box or the Q&A box to put up your questions, and if we have questions that we haven't answered, we'll definitely speak about them. Great. So let's start off. Yeah, Vikram, just to confirm, you can see me, right?
Yes, I can see you. You can see me, hear me?
Yes,
All,
yes, you can see
all
screen as
right.
well.
Okay.
Okay, great. So yes. What we'll be covering today is a standard or general history. This is usually the format that's used in an internal medicine setup or a surgical setup because they sort of go well. At least the format goes hand in hand. An OB/GYN history is quite different from your usual history because you have to ask specific questions with respect to obstetrics and gynecology. Pediatric history is very different. Now, again, you know, there's a very good, very famous saying in pediatrics that children are not tiny adults. They are their own entity and they have their own physiology, their own way of functioning, their own mentality, and that's why you need to have a separate history for them. An emergency history is also very important, and again, this is a completely separate entity. So these are the four types of histories we're going to be covering. Hopefully, you get a very good idea of them. And yes. So now we move on to the importance of history taking. Why is it important to take a history? Why is it so important that, if you're in your whoever's here and you're in your preclinical years, that means your first to third years, uh, you will be told in some time, especially starting third year when you start doing propedeutics, that most of your diagnoses, most of your differentials come out of your history. Yes, the physical examination is very important, but you don't do the physical examination until and unless you have done a thorough history taking. So that's one of the very important reasons to fact find, to understand what exactly is important to the patient, what is concerning them, what do they expect out of the consultation, for how long it's been going on. These are very important questions that you need to ask that will then lead you to your differentials because the differentials might be different for an acute setting or a chronic setting. And therefore, you might want to find certain patterns that would match very, very particular conditions. Once you've sorted your list of differentials, you haven't come to your final diagnosis, and that's why you need to identify the possible diagnoses. For that, you need to identify the right investigations, and therefore, once you've come to a conclusion of what your investigations have told you, then you can give the right therapy. And something that I don't see a lot of medical students focus on, because obviously, when you're in an exam, you want to say everything in an OSCE, you want to say everything, is avoidance. If you go to any clinical setup and you tell them, yeah, we want to do this investigation, we want to give this treatment, there's a very good chance that you're going to be hammered by them because it's very important in a clinical setup to think even financially as well. Not all patients will come to you with, the highest level of insurance, or even if they're self-paying patients, they're not going to come with, heaps of cash saying, okay, we can do this as well. So you need to be able to understand what to avoid, what sort of investigations to avoid, what sort of therapy and treatment to avoid, because this can not only harm the patient, harm their body and their physiology, but it can also harm them financially, which is also another strain that as doctors we need to take care about. But yeah, you'll know more about this when you enter any clinical setup. Anyway, so now without further let's start off with general history taking. So this is the one regarding internal medicine or surgery. So the first and foremost thing you do, the absolute first thing, You ask them what is their presenting complaint, what is bothering them that they've come to see you, how history start with open questions, usually, so that you can get a field on which you can start asking your closed questions. Uh, Once you've started off with that, you'll have a very good format to go with. And I think that's going to help you quite a lot. So you start by asking questions like, what brings you in today? Once they've given you a complaint, oh, doctor, I feel dizzy, or doctor, I feel I have this pain in my abdomen, then you can ask them to describe it further, right? From there, you go to something called the history of presenting illness. Uh, this arguably might be the most important slide, or rather, the most important bit of your history taking, because you narrow down a lot based on just this one slide. And worldwide, the Socrates acronym is used. Now, again, you need to keep in mind one thing. Most patients, they might come to you with respect to a complaint of pain. Now, if it's pain, you can ask them what the site, onset character, so on. We'll go through all of them. But let's say they come to you with dizziness. You can't use site for dizziness. Like, where do you feel dizzy? You just feel dizzy. That's it. When did it start? Onset? Yes. You can ask questions like these. So, depending on the presenting complaint, the use of the Socrates acronym can change. That's the overall point of what I'm trying to tell you. Uh, so, how do you use Socrates acronym? You start off by site, the location exactly where they have any pain or any tightness with respect to asthma. They might have chest tightness. They might feel it sometimes upwards. They might feel it sometimes downwards. It depends, or it might be their entire chest field. So these kind of questions are very important. Where is the pain, or where is the symptom that they're feeling? Onset. When did it start? Super important. It helps you. It gives you slight idea of whether this is an acute or a chronic case. Sometimes you can't differentiate between an acute and a chronic, so you can say this is subacute. That's something you'll learn later, but I think for everyone's level right now, I think acute and chronic is the right way to go. When did it start? Very important question. And what were you doing at that time? Maybe they were doing something that triggered a particular symptom in them, or the feeling that they've come to you for. The character. What is the character of the pain? And you can say the character of the dizziness. You can characterize dizziness, yes. Whether they were losing balance, like they were walking and they couldn't walk in a straight line, something like that, or they felt like they were just staying still. They had a change in position and suddenly the world was spinning around them. Just this question can help you differentiate between vertigo, which is peripheral in nature, which means related to your inner ear, your labyrinth, your cochlea, or it could be something cerebellar related. So you know that one is emergent and one is not. And that's how you then, you go ahead with the rest of your history taking, or let's say even any therapeutic plan. Radiation. This is mainly with respect to pain and tenderness mainly. Let's say a patient comes to you with epigastric pain. It radiates to the back, very pathognomic of pancreatitis. So that's why, like, hence these questions are very important. Associated symptoms. Anything apart from the current symptom they are presenting to you with that might give you further clues. Fever, nausea, any numbness, burning during micturition, any night sweats, super important questions, because these can help you construct an overall pattern, like I mentioned in the previous slide, a pattern that can direct you towards a specific diagnosis. Timing. Is it constant pain or episodic? Is it constant dizziness or episodic dizziness? Constant tightness, episodic tightness, very important questions. And how long does it last for? Uh, let's take the example of dizziness. If someone's coming and telling you that they're constantly dizzy for a day, and that before this they weren't, you might want to look into something very acute and very emergent, maybe a cerebellar problem, maybe a stroke, even depending on the risk factors. Something episodic. Doctor, it happens for like 30 seconds and then I'm okay. This could point you in the direction of benign positional vertigo. That's why these questions are very important. Exacerbating, alleviating factors, very important. What can trigger the symptom, or what can actually decrease it? Is there a medication they take that decrease it? Usually, this question gives you a positive reply when you're asking them, when a patient presents to you with a symptom of heartburn, and they come and tell you that, yeah, doctor, I have some heartburn, I have some chest pain, and you ask them, do you do anything with it? They're like, yeah, I just take a tablet of Gaviscon and it goes away. So this can give you an idea with respect to where you should move towards a cardiac cause, a musculoskeletal cause, a gastrointestinal cause. Therefore, these questions. Severity, very important. You end by asking a question on an objective scale. On a scale of 1 to 10, what would you rate it? In fact, this particular question you should be using every time you see the patient henceforth. Because let's say they've come in with pain or they've come in with a dizziness and it's a discomfort on the scale of 8 or 9. You see them maybe the next day on your rounds, and let's say they're an inpatient. And if they say it's 4, that means what you've been doing is clearly working. And therefore, that you should continue it, and your diagnosis, or sorry, your therapy should be catered towards the diagnosis that you first thought. So this is how you use the Socrates acronym: site, onset, character, radiation, associated symptoms, timing, exacerbating or alleviating factors, and the severity. Right. Next up, ideas, concerns, and expectations. Now, this slide here is kind of a controversial one, and I'll tell you why. Because most doctors that I've seen don't necessarily use this. I personally, when I've been taking histories, I have only used the concerns part of this. After I'm done with the history of presenting illness, I usually just ask them what is the biggest concern they have right now. The reason I ask it is some patients can be such that they have a myriad of symptoms. They have everything. They have neck pain, they have burning and micturition, they have headache, they don't wear their specs, then their eyes hurt. They can have everything. That is why I asked them one question: what is the biggest thing concerning them right now? And usually that propels you. Why this slide is here is because let's say you're going for any OSCE examination and you ask this, you are definitely walking out with great marks just based on this particular slide. What it means is the acronym I stands for ideas, concerns, and expectations. The idea is to ask the patient, what do they think is wrong with them? What do they think has caused their complaint or discomfort? And a lot of doctors actually prefer asking them, like, what do you think is the cause? But some of them don't. Concerns. What is the biggest concern that they have right now? Again, like the reason I explained, they can have a myriad of symptoms. Expectations. What are you hoping to gain from the consultation? Are they just coming for a medication refill, or are they coming because they actually have another problem that they want to bring up with you? So very important with respect to your examinations, your OSCEs, if someone's going ahead and giving PLAB 2, definitely use this right after your HOPI. Please do. It's a game changer just for exams at least. Right. Review of systems. I think probably the second most important slide after the history of presenting complaint. And that's because certain diseases, they have a systemic presentation, but the patient feels only 1 or 2 of the symptoms. And that's very important in multisystemic diseases. So the overall idea behind the review of systems is to get additional relevant information with respect to other systems. So what I remember from my internal medicine consultant that he told me was, Karthik, the best way to go about it is to go from a head to toe manner. So you start from the top and you end up at the toe. You start with systemic. So overall, non-specific, fever, change in weight, night sweats, very important questions to ask, because usually when you're focusing on a particular system, you forget that certain symptoms can manifest, in the entire body. Neurological, yes, we start from the top. Any headache, any sensory or visual disturbances. Cardiovascular, any chest pain, palpitations. Respiratory, any shortness of breath, any cough. If they have any cough, is it productive or not? If it's productive, what is the color of the sputum? Very important questions. Just the color of the sputum can give you 2-3 different diagnoses. If it's white, it could be TB. If it's white with blood, it could be TB again. If it's frank blood, it could be an autoimmune process, could be cancer. So it gives you a very good idea of with respect to what direction to go into. Gastrointestinal, lot of questions in review systems for GI. Vomiting or diarrhea, are they bloated? Have they had any blood loss? Have they seen any blackish coloration of their stool, or have they actually passed fresh blood per rectum? Any episodes of vomiting blood? This is usually pretty common on weekend nights. People have gone out to party or something, and they come out and they have like these vomits. They retch, and then there's some blood-streaked vomit, and that could point you in the direction of malorialized tear. Hence, why the questions are important. Genitourinary, polyuria, polydipsia. Do they tend to drink too much water and therefore urinate a lot? Did they have any groin pain, any menorrhagia? Very important with respect to the OB-GYN department. any menorrhagia, any dyspareunia. Dyspareunia is basically painful sexual intercourse, and it's a red flag. It's an immediate red flag. You have to get it checked. Musculoskeletal, any trauma, limb weakness, and any joint pain. The trauma part, a lot of people end up forgetting. That's why we've mentioned it, exclusively here as well. That you need to mention, you need to ask with any questions with respect to trauma. Any person comes in, oh doctor, I have knee pain. What were you doing at the time? I was playing football. Anyone hit you? No. Did the ball hit you? No. Did you slip? Yes. How did you slip? Did you twist your knee? Yes. Probably an ACL tear. 5 questions and you've gotten your diagnosis. That's why it's so important to follow a particular format so that you can reach your diagnosis in the quickest manner possible. And finally, dermatological, any rashes, any itching. A lot of people don't realize this, but dermatology is pretty much multisystemic as well. There can be diseases that have manifestations dermatologically, but the patients usually ignore them. Therefore, they never show up, or at least they never talk to the doctor about them. Right. Your I would say at this point, 50% of your history is done. Now you just have to ask certain questions with respect to their past, their family history, their social history, and you're basically done. So past medical and surgical history. Ask for any past medical conditions, especially chronic conditions like asthma, diabetes, hypertension. It is very, very important because your therapy can change. The reason this is important is because let's say the patient has asthma and you have given them let's say a beta blocker for their cardiac issues. A beta blocker is contraindicated in asthma, or at least some beta blockers are. So your therapy has to change with respect to the patient's current physiology. And that's why it's important to know for any past medical surgical history. Ask for any previous surgeries done. And yes, this includes C-sections for women. It's important to document this as well. Ask for any allergies. You ask it here, definitely. You ask for any allergies because let's say a patient comes in, they have a fever, they tell you they're allergic to paracetamol, and you've just started a paracetamol drip. This patient's going to blow up. They're actually going to have edema, urticaria. You'll have to ultimately end up using an EpiPen. So it's very important to ask for allergies, not only in the ER and acute conditions, but also in an internal medicine or a surgical OPD setting. Medication history, very, very, very important. Maybe the therapy you are giving them right now is going to act or counteract with the medications they have already been taking. Or maybe the symptoms that they're coming to you with is a consequence of the medications that they're taking. So it's very important to document this, whatever medications they're taking. If it's heart medications, write all of them down, asthma, hypertension, whatever it is. It could be any chronic or acute condition, write them down for sure. Family history, something very, very significant, especially in internal medicine setting. In the internal medicine OPD, most of your patients are going to come up with, and finally, when you diagnose them, it'll be diabetes, hypertension, some sort of peripheral arterial disease, anemia is very important, dizziness. These are usually the ones that you see in an internal medicine setting. And when this happens, some of these diseases, you do need to ask for a significant family history. Let's say it's hypertension, you need to ask for risk of cardiac factors or cardiac risk factors in their family. What about their parents, any immediate family members, any siblings, any cousins, stuff like that. It's very, very important to take under consideration the family history as well, can definitely point you in a different direction. Social history, yes, also very important. Within all of this, I'd like to highlight one point specifically, and that would be travel history. And I'll tell you why. So we start off with accommodation. Again, it depends. It depends on whether you want to ask these questions, but it also depends on what etiology you're suspecting. If you're thinking infectious related, yes, you should definitely ask for accommodation. Diet is something I started asking when I take histories recently. Smoking and alcohol intake is a constant question. Travel history. Travel history is very, very important because sometimes certain diseases are not endemic to where you are practicing. For example, let's say that, so we're here, like I'm here in Dubai, Vikram and I are here in Dubai. Very rarely will you hear a case of malaria, but it does happen. Well, that's because it's not endemic here. And let's say a patient presents to you, they have some sort of right upper quadrant pain, they are jaundiced, and you find out their hemoglobin is low, their bilirubin unconjugated is very high. Okay, it's some sort of hemolysis. You never ask the travel history, you will never think of malaria. There's a very important quote with respect to medicine that I learned recently is, the eyes are not going to see what the brain doesn't know. So it's very important to think in that direction so that you can ask those questions and actually see it as well. Next, recreational drug use. Again, it's a controversial question. Recreational drug use and sexual history. Again, if appropriate, do ask it, because sometimes you get very, very important chronic diagnoses. For example, hepatitis, HIV. These are very, very important diagnoses when it comes to altering the course of a patient's, not just their therapy, but their life, because now they have to be either on lifelong therapy for something, or they need therapy that is going to be so financially straining that they might have to go back to their country to receive it. So it's very important. If you suspect it, ask it, but don't shy away from it. Next up, we have just closing the consultation. So overall, you've covered everything in your internal medicine surgical OPD now. You will ask them if there are any concerns. Is there anything else they would like to have addressed? And after this, you will move to the physical examination. Now, that's not a part of this webinar, but this is overall how you take an internal medicine or a surgical history. Right. So next up, we have an obstetric and gynecology history taking that will be done by Vikram. Yeah. So Vikram, take it away.
Yeah. Okay. Good evening, everyone. Thank you so much for lending us a couple of hours of your Sundays. See, our main goal as the alumni committee was to help people understand how important certain topics are. And we especially have learned how important history taking is after leaving university, because nobody really tells you how history taking is done. I mean, you get the script, they teach you how to do it, but after that there's nothing really to back up. You don't really practice too much, especially if you're in Tbilisi, and you don't get to communicate with the patient. So we just wanted to give you guys like a manuscript on how to do it, because the first day you go for your internship, every doctor's going to be like, okay, the first order of business for an intern, go take history from this patient. And at that point in time, you can't sit in Google and study. So we're just trying to make your lives a little bit easier. Okay, so let's talk about an OB-GYN history. Yes, Karthik, can you go to the next slide, please? Yeah. So an OB-GYN history is a little bit more complicated than a normal surgical or a general history, which Karthik just explained about. And I'll tell you why, and it's pretty obvious. It's because you're dealing with two lives, not one. So you're dealing with a fetal life as well as the mother's life. And usually all the disorders or most of the pathologies are very related. So that's why you have to check each and every aspect of this history, and you have to make sure you ask questions in a very systemic way, because it's very easy to lose questions, in the heat of the history taking. So you have to make sure you have a checklist, and after that you can go ahead and tick one by one off and make sure that you haven't missed anything, because missing something could mean very dire for the patient as well. Okay, we'll start off. Next slide, please, Karthik. Yeah, again. So when a patient comes to you, first thing you ask, what's your presenting complaint? What brings you in today? How can I help you? And bear in mind, in most countries in OB-GYN, when the patient comes to you, they could be the patient might have just gotten pregnant. The patient might be almost at term. Patient might be coming in between for a test. So make sure you account for all that. And the patient will be with their family most likely. Where most of the times the patient is with their family, make sure you address everybody in the room, and then you ask the patient, what brings you in today? How can I help you? And if she's having a problem, or if it's just a normal test, you understand the motive of the meeting. Yes, Karthik, next. Okay. So this is the very first thing you got to learn in an OB-GYN history taking. What is GTPAL? So GTPAL is an acronym that's used to summarize for you to get an idea of the whole obstetric history of the patient. So what's that? Every female that's coming to you pregnant, it could be her second birth, could be a third birth, could be a first birth. So you need to learn about all of that. And it's not necessarily that they have already been admitted in the same hospital. It could be a new person. And yeah, so the first thing you check about is GTPAL. Now let's break down this mnemonic one by one. What's gravidity? Gravidity stands, G is gravidity, and it's the number of pregnancies, including the current pregnancy for the women. Simple as that. The number of times the woman has gotten pregnant. That's it. A term that is not there in this mnemonic but goes hand in hand with gravidity is known as parity. So parity is basically the number of times the woman has given birth to a fetus that's above 24 weeks of gestation. Simple. Whether it's a live birth or whether it's a stillbirth, you need to check gravidity as well as parity. So that's why when you go through notes or histories of doctors, it will be written, for example, G2P1. So what does that mean? G stands for gravidity. That means the patient has gotten pregnant twice. And P1 says that she has one living child. Okay. Then we go to T. T stands for term, and that's the number of pregnancies carried to 37 weeks. So we know the term pregnancy, it varies from country to country, but what's most likely used worldwide is 37 to 42 weeks. That is usually a term pregnancy, or anything above 37 plus weeks is a term pregnancy. So when we go to preterm, preterm is anywhere between 20 to 36 and the last week of the 36th, the last day of the 36th week. Now, preterm, also the number changes from 21 to 20 to 24 to 26 in different countries. But what's most worldwide recognized is 20 to 36 weeks and the last day of that 36th week. Abortion is the number of losses prior to the 20th week. So before preterm, any abortion is any losses, miscarriages, all that. And living is the number of living children. So GTPAL, again, is this main acronym, gives you a whole, in just 5 letters, gives you a whole idea of the obstetric history of the patient when she comes to you. All right. Karthik, next slide, please. Okay, so here, if you notice down, I've just given you a quick sample. So you see Susan is experiencing her 4th pregnancy. So already you can say G is gravida 4. Her first pregnancy ended in a spontaneous abortion at 8 weeks. So you have A is 1. And the second resulted in live birth of twin boys at 38 weeks. That's still term. So you have 2 there. And the third resulted in a live birth of a daughter at 34 weeks. So what you can see here is you have one preterm birth, the daughter at 34 weeks, 2 term births, 1 abortion, and she has 3 living kids. So this is how you basically make a rough formula around the obstetric history of a patient, and this can be done in the first 2 minutes. So that is your primary goal, because it will help you correlate with everything that comes along with it. Now, once you've established that, let's move on to her current pregnancy. Why is she there? You get to know the details about the current pregnancy of the woman. The first thing would be LMP. So LMP stands for last menstrual period. You just have to ask the patient, when's your last menstrual period. It might vary from time to time, but it would be preferential. And nowadays people do measure this LMP and keep it recorded. So because it really helps in calculating the other 2 formulas. So what's GA and EDD? EDD is estimated delivery date. Again, extremely important. But how do you calculate EDD? Quickly, I'll just tell you. If you guys want, you can just write it down. EDD is calculated from the LMP. So you take the patient's LMP, last menstrual period. You deduct 3 months from it. Okay. You add 1 week or 7 days to it, and then you add 1 year. Again, EDD, you take that patient's last menstrual period. You deduct 3 months from it. Then you add 7 days and you add 1 year to it. So that is the rough estimated delivery date of the patient. Now, what about gestational age? Gestational age is again very controversial. Nowadays, what most people do is they just take the LMP, they just take the EDD, and then they just take a calendar and calculate it. That's the easiest way to do it. But if you do want a formula, you just do the same thing. You take the date of the visit of the patient. Okay, like for example, if they're coming today, and you take their last menstrual period, which was say 4 months back, and you calculate the days in between that. That gives you the gestational age. So how many weeks the woman has been pregnant. So these are the 3 major key points that you need to, if you're taking history, you need to calculate it, because any consultant you go to will definitely ask these 3. And if you haven't done it, that doesn't look good. So the main 3 things are LMP, gestational age, estimated delivery date. Then you ask them about any prenatal checkups. What checkups have they done? When have they done it? Have they stuck to the dates of the checkups? Because nowadays we have all these different checkups that are done. Ultrasound checkup, you have your genetic counseling checkup, all these checkups that need to be done. And if they have been missed, you know that it could lead to a disaster. So that's why you make sure if they've stuck to their prenatal checkups. Then you check history of drugs. As we all know, from the very first day of medical school, they tell us that there are some drugs that can cause problems to the mother as well as the fetus. These are known as teratogenic drugs. For example, I can give you salicylates, tetracycline, misoprostol, ACE inhibitors, very important ACE inhibitors, because it can cause anuria. And these are basically for all the first to third years. I know you guys won't understand much, but just remember there are teratogenic drugs, and these drugs can cause problems if used antepartum. If used during the pregnancy, it can cause problems to the mother as well as the fetus. It can cause deafness in the child. It can cause growth restriction. It can cause a lot of things. So you need to check the history of drugs the patient has been using, what they've used in the past, and what if they're on any medications now, what are they on now. Then you check off any infectious history. If the patient felt signs of any infection, so that's a pelvic inflammatory disease. If she's feeling any symptoms within her lower abdomen, if she has a history of UTI, or she's currently there for a UTI, she's feeling burning urination, she's feeling a lot of urine, less urine, all of these are symptoms. And if there's anything informed about the prenatal tests, so when she did do her prenatal checkup, did they give her any diagnoses, or did they tell her everything was normal, or did they tell her no, there's something that we need to check later on? So you need to know about all of these so that you don't miss out on anything. Yes, Karthik, next slide. Yeah, so now you move on to any complications from previous pregnancies. So this you ask the patient, if say she's a second or third pregnancy, and she's asking, you have to ask the patient, did you go through any complications antepartum, postpartum, peripartum? If did you go through any complications during any of these phases? Because as we know, conditions like preeclampsia, placental abruption, gestational diabetes, all of these can occur, or the woman is predisposed in subsequent pregnancies. So you need to make sure that you have the sufficient prophylaxis ready to deal with it. Especially preeclampsia and GDM have to be dealt with immediately, because it can be life-threatening to the mother and the fetus. Then you got to ask about frequency of fetal movement. So this you will see a bit later on, maybe close to the third trimester. And usually the recorded number is about 3 to 6 movements every 10 minutes. So you have about 30 to 60 fetal movements every hour. It varies from person to person. So you just have to make sure that you're recording this and you submit it to your superior doctor or the consultant in charge, so that they have the necessary information in case anything goes downhill. And another complication that needs to be addressed is bleeding, blood clots. You need to ask the patient if they've had any sort of spotting, bleeding, antepartum during the pregnancy, and whether she had any bleeding complications in the previous pregnancy, because that's again very important. And as we know, it can cause severe blood loss, can lead to postpartum hemorrhage. It's extremely life-threatening to the mother itself during the when at time of giving birth. So this needs to be addressed. And also you can ask if they've had any vaginal discharge, consistency, color, smell, volume. Make sure they're not going through it, they're not suffering from a UTI or any other vaginal related disorders. Yeah, now you move on to the review of systems. This is usually done extremely quickly in OB/GYN patient, and it's the exact same, or we can use the exact same order as what Karthik explained earlier. But some things are very important here as well. You have neurological, you can see headaches. Headaches are very common in, in people in pregnant patients, so it's fine. And you have cardiovascular problems. If people will have high blood pressure, that could lead you to um, coming to diagnosis of preeclampsia, then respiratory disorders, flash edema. It can cause if the patient comes to you with edema, it's very normal in pregnant people. But if they're having breathing problems, you could say it's flash pulmonary edema, and that could lead you to more diagnosis. So my point is the same review of systems as the general history, but just make sure that you address each one of them. Don't skip it, because it could lead to something that you can sort out before the patient goes into a deeper pathology. Yeah, next slide. Okay, gynecological history is basic. Nowadays, cervical screening is done everywhere, every hospital, and it's mandatory. Make sure that the patient is sticking to their dates, as well as the patient is informed about what these tests are and why they're important. STIs, endometriosis. Endometriosis is basically the inner lining of the uterus growing elsewhere. It can cause pain, it can cause bleeding. It's important because they don't really, they don't really affect the pregnancy as such, but it can affect the mother. Bartholin cyst is basically a gland that's present on the vagina, and this is useful for lubrication. And usually, these cysts, if a cyst is formed, it can enlarge in size and cause obstruction. So that's why it's important. Ectropion is also the same, related to the same basically, and malignancy. Malignancy is also very important because if the patient has a history of malignancy or a family history of malignancy, you know that you have to make sure that they're going for the right tests. And these are all basically prophylactic to avoid any problems in the future. Now, one problem that nobody really taught us back in university, or no book ever says it, one very, very important fact is that when you're taking a gynecological history or an obstetric history, one thing you need to address is how sensitive of a matter it is. So as an intern, when you're taking this, you need to make sure that you take into account the patient's, sentiments, feelings. When you're asking, for example, you're calculating GDPAL, you're asking the mom about abortions, and the mom, you find out that these are, for us, these are just numbers, but for them, those are actual people who have gone through a miscarriage and have gone through stillbirths. So it's very, very sensitive matter for them. So you make sure you address those, and you make sure you do it respectfully. And you can, if you want, you can ask the patient in private as well, to avoid, embarrassment or anything. Basically, you need to make sure that, and this nobody tells you, everybody just says, go take the history, that's it, come back. You need to make sure that you do it in a very respectful manner, so that you get accurate information and the patient is cooperative. And this is one thing that you have to keep in mind, not just for OB/GYN, for every patient you ever meet. Make sure patient confidentiality is upheld, and that you're taking into account the patients and the family's sentiments and feelings as well. And you are addressing them, which will make them, that it's seen to them that you are empathizing with them. So then they'll become all the more cooperative, and you'll get all the information that you need to to come to a conclusion or a diagnosis. And yeah, next slide, Karthik. Additional history. This is your basic. You can ask past medical history, past surgical history. As Karthik said, C-sections fall under it. Drugs and allergies, again, very, very, very important. If a patient is allergic to it and you don't know about it, and you do end up, somebody in the hospital ends up administering that patient with that medication, it could be life-threatening, and it could lead to a fatality as well. So be very careful about that. And family and social history is, again, these three things are taken in any history, even in an emergency history where the patient has, is barely conscious. These are the three questions that you'll ask. It's very important, and please keep in mind that these three things have to be asked every single patient, every single time, no matter the circumstance, no matter the environment. They have to be asked. Yes. I'll take next. Okay. So that was basically a rough about the OB/GYN history. If you guys have any questions, just note it down, keep it for the end, and we can clear that out. We can answer your questions. And yeah, that was basically it. You just need to make sure that you have all in all idea about the patient's obstetric history, gynecological history, and whether the patient is prenatally gone for all her checkups, and whether the patient is on any prior medication, whether how is their social environment, all this, because this is extremely important to avoid any future problems. And if a mother comes with a peripartum problem while giving birth, it's very difficult to manage. Something that could have been managed earlier, like preeclampsia, if it shows up, it could lead to eclampsia as well. It's very difficult to treat and avoid damage to the fetus as well as the mother. So yeah, please keep in mind. And yeah, so now Karthik will go ahead with the pediatric history taking, and then I'll be back for the emergency history taking.
Yes. Hi guys. I hope everyone's learning a lot. Thank you, Vikram. There's a lot of stuff that Vikram mentioned that even though I've done my OB/GYN rotations, there's some stuff that I was recalling. There's some stuff that was absolutely new. So that's great. So I can only imagine how much the rest of us on the webinar are learning. Anyway, so we're gonna go ahead with the pediatric history taking. Now, as I mentioned before, uh, you need to look at the pediatric population as its own separate entity. You cannot just assume that they are tiny adults. It does not work that way. It's very different for children, and it's very different for different age groups of children. So that's very important to take into consideration, and I think we'll be targeting that aptly today. So very similar approach, but a different format, a different sort of question. Current complaints, yes, you'll definitely ask about them. Similar symptoms in close contacts if you're suspecting an infectious etiology. Travel history. Now, why I've put up these three as the first side of history presenting illness, because there you saw Socrates acronym, here it's completely different. So why? Yes, you will use Socrates here as well. But you need to keep in mind that these questions that you're asking, you might not be able to get the answers from the child. These questions have to be answered from the parent side, which is why there has to be a therapeutic alliance, not just between you and the child, but you, the child, and the parents, or whoever the guardian is, the family, uh, which might add to some confusion, which is why pediatricians have to be very, very on point with respect to the questions they ask. And I mean extremely, like certain things you can observe in internal medicine and surgery, but certain things in pediatrics, if the parents don't tell you, there's no way you'd know them, right? And we'll get to that as well. So current complaints, yes. Obviously, you'll speak to the parent about this mainly, and they'll give you a brief on it. Similar symptoms in close contacts. Now, why I've included this here in the history of presenting illnesses, because children don't have the same immunity that adults do, which means that they are more likely to get infections very easily. If they're going to a nursery, they're diabetic, okay, probably hepatitis A infection, probably some sort of, rotavirus infection, super common, super common. So it's very important to ask the setting they're in, who are their close contacts? Have there been any breakouts in the school or the nursery they go to? Has there been anyone, their sibling at home who they play with, that has been infected? Maybe an influenza case. Very common in most places in the world between October to March, influenza season. Super common. So it's very important to ask regarding similar symptoms in close contacts, especially if you're suspecting an infectious case. Travel history. It's the same reason as why it's included as the close contacts point. Children are more susceptible to diseases. They usually fall sick when they travel. So it's very important to ask them regarding travel history. Where they've come from as well is very important. And based on certain locations, you can understand what sort of a presentation can give you what sort of a diagnosis, or at least, again, infections in case, you can understand what sort of organism it might be, and you can start your empiric antibiotic therapy, or just start supportive treatment. So again, these are things that you learn more clinically when you enter a clinical setup, as in a hospital or a clinic. But I think overall, theoretically, it's very important to start with these three. At least that's what my consultant told me, that at least you can start with these three when you're dealing with most children above the age of 1. Review of systems. Again, the exact same as back there, except one point. Not every child is going to be active enough to tell you that they're having a headache. Because when children have an issue, they get irritable, they go quiet. Even the tantrums they throw is only in front of their parents, so their parents are the ones that know everything. So your questions have to be slightly uh they have to be a bit different. They have to be catered towards the parents, such that it's something that the parent might have noticed. For example, if there's a patient that comes in with a fever and you can't explain it and you suspect a UTI, now you're not going to be able to get the answer from the child if you ask them, do you have burning when you pee? It's not necessary. It's not necessary the child is going to comply with you. So instead, the question has to be directed to the parents, like, have you noticed that your child gets a little bit more irritated or more irritable, more anxious, more angry after they've gone to the washroom? Questions like these. So you have to cater it to the parent such that they can actually give you an answer from what they've observed, right? And it's very important as pediatricians to also have a very high, or at least when you're taking a history in the pediatric department, to have very high level of suspicion for different diseases that the child cannot complain about. Because then even if you will ask for that test, you can go ahead with it and you can get a result that might, save a lot of time for the child and the parents. Because in pediatrics, you don't treat just the child, you're treating the child and the psyche of the parent. So it's very important. You're treating at least 2 to 3 patients at once per case, which is not the case in internal medicine or surgery. Even obstetrics, and yeah, obviously, but in pediatrics, it's quite different. Additional history. This is where pediatrics completely takes a different turn. Immunization. The first question in additional history has to be immunization based on the age appropriate immunization. If this child is, let's say, 3 years old, the next MMR dose is at 5. You can't expect the second MMR dose to be given. Don't worry about it. It's okay. Even the parent might come to you, doctor, maybe this is measles. It could be because of that. Don't worry. It's not indicated. Don't worry. We can give symptomatic treatment and it's fine. But it's important to document it. It's important to note it down, because later it can become a problem for you. I mean, medical legally as well. And also, let's say that you could have administered different therapy just to, cater to that particular patient or that particular case separately. And it could have worked. But if you haven't asked the immunization history, you won't know what diseases are they covered for, especially in developing or rather less developed countries. It's not necessary that the patient or the child must have been given a DPT vaccine, and they come to you with a swollen throat and you check the back of their throat. It has this massive gray membrane and this gray clot-like appearance, this is most likely diphtheria. You need to start treatment ASAP. This is a pediatric emergency. But if you've not asked the question, how are you going to know it? That's why it's so important to focus on the immunization. Are they developmentally normal? Now, this is more of an observation rather than asking the parents. Yeah, you will definitely ask the parents, but it's more of an observation as well. Any dysmorphic feces, any clubbed feet, these are very important questions. Feeding history. Now certain questions here are not something you would ask, let's say, a 8, 9 year old child. Obviously, again, that's why the additional history part of this is very age appropriate, or rather, it's age oriented. Feeding history, you're most likely to ask patients, I think, until 2 years old at least, because I have asked patients until 2, even 3 years old sometimes, that what feed were they on and what are they currently eating? Because sometimes children can just come with you because they're fussy eaters and they're weak. So, feeding history, were they breastfed, were they bottle fed, or were they mixed fed? Usually, you see patients nowadays, or rather, you see mothers nowadays preferring mixed feed. So, it's important to document this as well. Birth history, any complications during pregnancy or birth, super important. Super, super, super important. This is the exact reason why you have pediatrics and OB-GYN on the same floor in hospitals, because you can consult one or the other immediately, whether it's at birth, whether they're neonate and they've just been delivered. So the OB-GYN and the pediatric consultant can talk to each other and, give certain clues with respect to what might have happened. The rest of the three are the exact same as the previous history: past medical history, past surgical history, any drugs, any drug history that they might have been given. Sometimes asthma is diagnosed very early. Sometimes celiac disease is diagnosed very early, and they're given certain drugs with respect to that. Any allergies they might have, yes, also possible that they might develop it very, very soon. Family history, not so significant, but it's better that you ask it. Yeah, this is a particular history, very, very specific to neonates and infants. Now, let me start by telling you the definition of neonate. A neonate is defined as a child that has just born until 28 days. Until 28 days of life, a baby is considered a neonate. And until age 1, a baby is considered an infant. The history is slightly different with respect to this population. You have to obviously know the age in months and the gender, and I'll tell you why. Next, you need to know whether they were born preterm, term, or postterm. Very important, because based on that, you can think whether the birth weight is appropriate or not. And the mode of delivery. Why is that important? Maybe their current complaint is with respect to their mode of delivery. It's very important to know this. Normal vaginal delivery, is it NVD? Is it assisted? Maybe it's assisted with vacuum or with forceps. It's very important to know, because forceps assisted vaginal deliveries are a very big cause of cephalohematomas or maybe some other head trauma. And therefore, it's very important to know, maybe the baby is just super cranky. Why are they cranky? Maybe there was an assisted vaginal delivery involved in their neonate. So it's important to take these into consideration. And if it's a C-section or not, also pretty important. So you need to know what is the mode of delivery as well. Next comes the current weight. And this is where you will connect the birth weight and the age in months. So this is a tiny clinical pearl. What my consultant told me. Whatever your birth weight is, right? So a normal birth weight for any child delivered at term is between 2.5 to 4 kilograms. Anything more than 4 is considered, well, slightly overweight, and anything less than 2.5 is considered diminished weight, lesser weight. Or rather, small for gestational age. That's the exact term, SGA and LGA, above 4. Let's say that there's a patient that was born at 38 weeks and their weight is 2.6 kilograms. On the 8th day, the mother comes for a follow-up and she says, doctor, but my child's weight is decreasing. Now, here's the thing. This is what my consultant told me. Your birth weight, whatever your birth weight is, until the first 10 days of life, your weight is supposed to decrease. After the 10th day, your weight will start increasing. So your weight at birth and your weight at the 10th day of life should be approximately the same. Because for those 10 days, you're going to get accustomed to life outside the uterus, and you're going to be losing some weight. You're going to be losing a lot of water. You're not going to be getting the same nutrients as you used to back in the uterus. And therefore, in those 10 days, your weight can decrease. It's normal. After those 10 days, your weight should only increase such that at 3 months of age, your baby's weight should be double the birth weight. Okay. And at 1 year of age, at completion of infancy, 1 year of age, your baby's weight should be triple their birth weight. I'll repeat that. In the first 10 days of life, weight can decrease. It's very normal. After 10 days, it starts increasing because you get accustomed to life outside the uterus. At age 3 months, your birth weight should be approximately double, right? Your weight at 3 months should be double your birth weight. And your weight at 1 year of life should be approximately 3 times your birth weight. So that's how you get sort of an insight with respect to how the age in months, the birth weight, and the current weight are related. And therefore, you answer the question, has there been appropriate increase in weight? If there hasn't been, you ask regarding feeding, or you ask regarding activity. Are they usually active? Maybe there's an underlying pathology and you need to investigate further. Were there any complications during pregnancy or birth? Especially for neonates, you need to ask this because neonatal jaundice is there's a very big burden worldwide on neonatal jaundice. Now, to be able to differentiate, this is physiological, is it breastfeeding, is it some sort of syndrome in the intestines, malabsorption, could be something related to the liver itself. It's very important to be able to differentiate. And your therapy changes based on that, where the bilirubin levels are and where it isn't. So any complications during pregnancy, maybe because of assisted vaginal delivery, there's cephalohematoma. Now that blood is going to break down, cause jaundice. It's very important to know these things so that you can cater your treatment towards that. Have they received age-appropriate immunization? You will not believe the number of patients that come into the OPD and say, and I mean, I'm just with my consultants. I talk to the consultant saying, "Doctor, we got one of the two vaccines that we were supposed to give at birth." It happens. It's very natural. You need to get accustomed to this, and you need to be able to understand that this is a separate set of population that needs to be counseled, that these vaccinations are important. So age-appropriate vaccination is very, very important, especially in neonates. Feeding, yes, for neonates and age less than 1, definite question. Are they on breastfeeding? Are they on bottle feed, or are they on a mixed feed? Means breast and bottle both. Intake output. Do they have regular poo and urine? So until the age of 1, you can say that the baby can poo maybe about 3 to 4 times a day. It's normal if they're on breastfeed. It's very normal, and it continues decreasing after that. Above the age of 4, you can expect 1 per day. Urine about 2 to 3 times a day. So it's important to consider what is regular and what is not. Is their output as much as what they're intaking? And based on what their intake is how is their weight? Is it appropriate for their age or not? Do we need to do more investigations or not? Are they term? Are they not? So this is overall the way you would target any history specific for a neonate or an infant. Yes, so now I'll hand it over to Vikram to speak about the last segment of this presentation, which is emergency history taking.
Yes, thank you so much, Karthik. I knew like pediatrics was bad, but this is very difficult and very different. But thank you for summarizing the whole thing. Okay, emergency history. It's a sensitive one because I'm currently in my emergency rotations and I'm still getting better at taking these histories. And yeah, I'm doing my emergency rotation in NMC Royal Hospital in Khalifa City, Abu Dhabi, and we have a pretty extensive one. So it's hard because the doctors in emergency are not always, they're not keen to sit and explain things to you because everything in emergency happens fast. So you got to learn these things on your own. Okay, so the main thing about an emergency history is that it's not the same as a normal history. You don't see the main thing. Any patient who comes to the emergency department are not coming in a state where they're ready to sit down and talk, tell about their family history, travel history, review of systems, and you can go and examine them completely. You don't have time for any of that. When the patients come to the emergency, they're in a state of bother, state of pain, and it's intolerable, and that's why they're there. Otherwise, they would have gone to the OPD. So this is one thing you'll have to keep in mind. And that's why I'm going to give you some insider knowledge on how my HOD taught us at emergency at NMC, and how the emergency department history is different from the normal one. Yes, Karthik, next slide, please. Okay. So it involves quickly gathering crucial information from patients who are usually presenting with acute or life-threatening conditions. Again, like I said, otherwise they wouldn't be there in the emergency department in the first place. So how he told us to do it is, imagine yourself, okay, imagine two lines of two directions you can go. On one side, you have something known as the primary survey and the secondary survey. And on one side, you have your normal history taking A, B, C, D, E. How you do it, your normal history, then like how Karthik explained, depends on the state of the patient. Now if the you could get a trauma patient, RTA, car accident patient, you could get a, anything, any patient, a patient coming with acute pancreatitis, extreme pain, they can't talk, they can't do anything, they just want medications and they just want help. So how you go about this is, on one side you have your normal history, one side you have a primary survey and a secondary survey. I'll just give you a brief what's a primary survey and a secondary survey. Primary survey also includes something called sample, which is extremely, maybe the most important mnemonic you need to know in an emergency setting. Yes, Karthik, next slide, please. Okay, so what's a primary survey? A primary survey is, just look at it as two steps. Patient comes to you with a certain problem, say they're having pain in the chest. Okay, a primary survey is just taking that symptom and taking all the information you need around that symptom. Okay, and coming to an immediate, at least a differential diagnosis, and giving some sort of medication so that you can stabilize the patient. So you use a primary and a secondary survey when usually you have an unstable patient, and you need to stabilize them first before you can carry forward with your history and your investigations, diagnosis, everything. One main thing that I wanted to tell you guys last time that I forgot about was, the main difference between histories is, and a good history and a bad history is, when you're taking a history, your goal is not to come to a diagnosis. Like, so when a doctor asks you to take a history, he's not expecting, yeah, doctor, this is acute pancreatitis or this is acute cholecystitis. No, they don't want that from history. Your goal of a history is to ask questions in such a way that you finally, at the end of this, when you say bye and leave the patient, you have 5 diseases or 6 diseases that you have narrowed it down to. And your investigations and your physical exam is exactly what pinpoints your diagnosis. That should be your main goal, not to get ask questions, close-ended questions, keep asking close-ended questions and come to a diagnosis. So here the problem is, in primary survey, what you need to do is differential diagnosis, and you make sure that the patient is stable. And how do you follow this primary survey? So we follow C, A, B, C, D, E, but the first C is, I know it's something that you guys are not used to. It's not taught in university. C, A, B, C, D is mainly used in a trauma setting, but you can also use it in an acute setting of another pathology. Now, let's break it down. Say, for example, a trauma, you're in your emergency department and there's a massive RTA case. There's 2, 3 patients who have come with severely damaged limbs and they're bleeding. So this is where, in this specific scenario, is where the C prevails over ABCDE, catastrophic hemorrhage. So here you make sure that you stop this catastrophic hemorrhage. For example, if the patient has a fracture, an open fracture in the leg, femur, you know that the patient's going to be bleeding out completely. So there's no point checking circulation, doing CPR, all this stuff in case you have to do it. There's no point doing all these things if the bleeding is not controlled, because the patient's just going to bleed out. So make sure you stop that, you apply a tourniquet, you stop that bleeding, then you continue with A, B, C, D, E, which is airway. I know I don't have to explain too much because everybody knows about it. Make sure that the airway is stable, it's open, the tongue is not compressing anything, and you have a patent airway. Then you check breathing and circulation. This is ideally in an actual real life setting. It's done at the same time. All these are technically done at the same time. Breathing, you make sure that the patient is taking breaths, and if they're not, if they are or they're not. And circulation, if the patient has a pulse or no pulse, you make sure if they don't have a pulse, you follow ACLS protocol. That's a whole different topic. But my goal is here to make you guys understand that you have to follow a C, A, B, C, D, E pattern in mainly trauma patients, or if you see any patients with active bleeding. This can work even if the patient is having constant hematemesis, bleeding, and through their vomitus. And you make sure you control the bleeding first, and then you check everything. And disability. Disability is where you technically check the GCS score of the patient, but not necessarily GCS. You don't have time to sit and check a GCS, so you check something called the AVPU scale. AVPU scale is very simple. It's GCS that's, comprised into 4 letters. A means the patient is alert. The patient is talking to you. The patient is responding to you, answering your questions, everything. V is the when the patient is, the patient only when you talk and you prompt something, you go touch the patient, then the patient is like, ah, yes, doctor, and the patient replies to you. That means that they're conscious, but they're not completely conscious. P is the patient is only responding to pain. So that's, again, you've narrowed down the GCS completely, and the only on inflicting pain on the patient, maybe you can do a sternal rub, or you can pinch their eyebrows and inside their socket eye socket. So these are the kind of things that you can do to inflict pain to make sure that the patient is responsive and that they're not brain damaged. And finally, U is the patient is unresponsive, and it's extremely important to call the ICU team or to call a code blue and then call an ICU team in this situation, because they'll be able to control it immediately. This covers disability, and exposure environment is just to get know what scene and exposure environment the patient was in and what tests you need to order. So this is basically a primary survey. For example, if the patient comes with a heart pain or a chest pain, you make sure that you cover up all your diagnosis around this primary survey first. You can within 2 minutes you should be able to come to a diagnosis of what a differential diagnosis, what pathologies that the patient could be suffering from, and make sure that the patient is stabilized first. Every emergency, they don't care what the disease is, they don't care what the pathology is, make sure that the patient is stable first. Okay, now we go to the next slide, which is sample. Yeah. So sample goes hand in hand with primary survey. So sample is a very, very, very constricted version of a history taking. Here, you're just going to ask the patient, like the patient comes to you, the patient is barely conscious, and you just have a limited amount of time and information that you can get out of them because you don't have time to ask about their family, where they stay, and all that stuff. So what you ask here, you ask the first thing should be signs and symptoms. What's the patient's complaint? What are they feeling? Most of the time, you can see this. Patient will be holding their stomach, or they'll be holding their head, or they'll be holding their leg. You'll know. The second thing is age, athleticism, and allergies. Now, by far the main thing in this, I would say, is allergies, because the goal of the emergency team mainly is to control pain, control the symptoms. If you need to do both, you need to administer medication most of the time, 90% of the time. Now, if the patient, for example, is allergic to paracetamol, you can't give paracetamol, you can't give analgesia, you have to think of other things. You have to think of, oh, can I give an NSAID, or can I give an opioid to relieve the pain? Because if the patient is free of pain, then you can go to that other line and you can ask them about their history, you can ask them about their you can do a physical exam, investigation. All this can be done in a routine manner if the patient is pain free and cooperative. Then medication. What has the patient been, like, for example, what medication have they been on? For example, if the patient comes to you with like dizziness or something, and you tell them like, oh, they came with you with a syncope episode, they tell you that they've been on some sort of beta blockers, for example, you can correlate. Or they tell you that they've been on aspirin, for example, you can correlate. Okay, maybe this was a TIA, maybe this was an embolism, a stroke. You can easily make diagnoses with these things. Then past history, past medical history. What if they're cooperative? You can ask them what problems have they had before, why are they here, are the two incidents related, all that stuff. Last oral intake is usually important for the medications. What dose to give, how much to give, what route to give, all these are very important. And events leading up to the incident, again, very important for all neurological emergencies, because if the patient's, for example, something is precipitated, like for example a seizure, you can easily make, okay, this is something that could be related to diabetes, type 1 diabetes, it could be related to any of that. So that's why sample is extremely important. And even if you don't have time to do anything, do C, A, B, C, D, E side by side, do science, do sample, and you should be able to come to a diagnosis, or at least a differential diagnosis, and relieve the patient of the pain. And then you'll be able to take a proper history, which is just following on internal medicine history, but just quickly. Yes, take next slide. Okay, so secondary survey. Secondary survey is done when the patient, this is where you calculate the patient is calm, the patient is stable. You can calculate the patient's mental state. Are they cooperative? Are they responding to you? Or has their AVPU GCS scale been affected? How is their airway? How's their respiratory rate? How's their oxygen saturation? These are the things that will show you, okay, maybe this patient is also having a respiratory disorder, or maybe they have primary respiratory disorders. Maybe they're chronically suffering from asthma or COPD or something, because out the oxygen saturation, the respiratory rate, all will give you an idea of that. Heart rate, blood pressure, capillary refill time. These are all the smaller, minute things that will definitely be it's needed to be done, but you have time to do it, and it's a generalized whole systemic review that you can do free. But that's basically it. How you need to do this in the emergency history is you primarily make sure that you stabilize the patient, because you don't have the time to ask a patient about their whole life story and the medications and all that stuff. But you just make sure you stabilize the patient, ask these very key points of this information that you need to make sure that you can, just for now, the goal of the emergency department not to treat the disorder. It's to make sure that the patient is stable so that they can send them to their respective departments and refer them there, and then they'll take care of that there. For example, if there's an OB-GYN disorder, they're not going to make sure that, okay, everything, the patient needs to leave the emergency and just go home. No, stabilize the patient, stabilize the fetus, send them to the OB-GYN department for management. That is the main goal of emergency, and that's where your history also should be pointed at, is to make sure that you can give a differential diagnosis to your consultant so that the management can be done immediately. And it is imperative that you make sure that you are not taking too much of anyone's time, and the everything has to be done on point and just focused at one thing, and that should be the sample, CABCDE, and the secondary survey. So yeah, that's basically about the emergency history, and I think we're done. I hope this was actually helpful for you guys, and I hope that if you guys have made like a document or you've written these down, they will definitely be helpful for you later on. Where there's nobody to teach you. The first day you go, they tell you, okay, go take history, go, and then after that, if you take a bad history, it's just, oh, you didn't learn anything. So I hope there were at least some points that you took away from this webinar, and hope we can do more of this. Maybe have subsequent webinars on the other things related to history. As Karthik said, there are physical exams, investigations, and all that stuff. So yeah, Karthik, and take over.
Yes. So what we're gonna do is we have two case simulations for you that we will be bringing up one by one, obviously. And I am just going to have our mock patient come in. 1 second. Yes. Okay. Mr. Patient, can you hear me?
Hello, am I audible?
Yes, yes, you are audible. Yes. Okay. So everyone, what we're going to do is that so far, whatever we've covered, right? We're going to use that two of the histories, not all four. We're going to use two of them, one for each case. In the first one, I'm going to be the doctor, and Neil here is going to be the patient. It's going to be an OPD visit in an internal medicine setup. So I'm going to use general history, and I am going to show you how exactly it's used so that you can have a better idea overall. Okay. So Neil, are you ready?
Yeah.
Okay, cool. Perfect. So, um, let me just confirm I'm audible.
Yes.
Cool. Perfect. Okay. So, um, okay. Simple stuff. Introduce yourself. My name is Dr. Karthik. Hi, how are you doing?
Hello, doctor. I'm doing okay.
Okay, okay, fine. We don't worry. We'll get to the bottom of that. So yes, tell me, how are you feeling and what brings you in today?
Yeah, I'm feeling a bit weak because
Okay.
I've been having loose motion for some time now.
Okay, you've been having loose motions for some time now. Okay. Can you describe your symptoms a little more and about the loose motions?
Uh,
Anything else you would like to add?
yes, I've been having these loose motions for like past few weeks, and I also feel weakness, so I thought I should get checked.
Okay, okay, fair enough. Uh, right. Regarding these loose motions, I'd like to ask you a few more questions. So, do you have any associated pain?
Yeah, I get cramps when I had to use the restroom. But
Okay.
other than that, there is also some back pain, I think. But it could be
Oh,
because of I lifted something wrong. I don't know.
okay, okay. When did these loose motions start? When did you notice them starting off?
So the thing is, it has been on and off for like past, I think 1 or 2 months. It happens and then it goes away. But I think it's because of my food habit. Also, I do eat a lot outside. But it's been on and off for like few months.
Okay, so you're saying it's been on and off for a few months. Okay, so I'm gonna assume it's in a now it's in a chronic setup. Um, did you okay? So you said it's on and off for a few months. Okay. You said that you have this pain that is crampy in nature. Can you point where the pain is, or is it all over your abdomen?
Just I would say like below my belly button,
Okay.
around that area, but it's like it's hard to pinpoint. It's just in
Okay.
stomach.
It's
Yeah.
it's hard to pinpoint. So it's diffuse, but in the lower region of your abdomen.
Yeah.
Okay. Have you noticed anything else associated to this pain, like maybe any fever?
Not really. I don't know.
Okay. Any body ache, generalized body ache?
A little bit. Yeah.
A little bit. Okay. Any problems with sleeping? Any nighttime sweats?
Nah.
Okay, no problem. What about the timing of these loose motions? Does it have anything to do with a particular time in the day, or it just happens when you feel like you have to pass through?
Uh, I don't know. Like after, of course, I eat, but I don't think I've noticed any like timing or anything.
Okay. Have you seen anything or have you done anything that might decrease these cramps, or have you seen another doctor? Have you had another visit before to get any medication, any treatment that would decrease these symptoms?
Nah, I saw something on Instagram, so I tried like some diet and eating this and that, but I
Okay.
don't think that actually helped.
Okay. And have you noticed any triggers?
Maybe it's when I eat outside, but again, like I don't know it. I didn't notice to be honest.
Okay, fine. No problem. Uh, all right. Uh, Regarding these stools, can I ask you, have you noticed any change in color of the stools? Maybe it's slightly on the darker side towards the black side, or very pale. Are they frothy? Does it bubble up?
Bubbles maybe sometime. I think they are grayish color and they are
Okay.
watery. But to be honest, a lot of time I don't pay attention. This is just it's just sometimes I see.
Okay.
Sometimes I
Okay.
notice. Yes.
Understood. This abdominal pain, this crampy pain that you mentioned, on a scale of 1 to 10, how much would you rate it?
Mm, Different time it's different, but I would say around 7, 8.
Are you having that same intensity of pain right now?
Right now I don't feel anything. Right
Nothing.
now I'm fine.
Okay. So this is mostly when you feel the urgency to pass through.
Yeah, right before I have to like
Okay.
while I'm running towards the restroom.
And the pain relieves after you've passed through.
Slightly, yeah. So I do feel it like few seconds, few minutes, but after I like I sit down or like relax after a few minutes, it does feel like slightly better.
Okay, understood. So I'm just going to summarize overall, and then I'm going to ask you a few more questions. You've come in for complaints of loose stool. You have some generalized body ache as well. You feel like these stools are slightly frothy. They bubble up a bit, and they're grayish in color. You've not noticed any discoloration of the stool otherwise. You have some generalized body ache, you said, and apart from that, you have some diffuse lower abdominal pain that you are not able to pinpoint at. All right? Okay, cool. So overall, I would just like to ask you, what is your main concern so far in this consultation?
The I have to go to the restroom multiple times,
Understood.
and I
That's
work
not
in an office, so that's not like ideal.
fair enough. Fair enough. I assure you we'll get to the bottom of it. I'd just like to ask you a few more questions. Have you noticed any headaches?
Sometimes, yeah.
Okay. Any problems in vision?
No, not really.
You're able to hear me properly? Am I audible? It's completely
Yes,
clear? Okay.
yes.
Do you have any sore throat?
Uh, no.
Okay. Any problems with breathing?
Not really.
Uh, have you noticed any palpitations?
What is palpitation?
Okay, my bad. Have you noticed your heartbeat, that you can feel your heartbeat, but without touching your chest? You feel
Uh,
like your heart is going to jump out of your chest.
no, no, not really.
Nothing as such. Okay, good. Have you noticed any other symptoms with respect to your at the time you passed through, maybe nausea, vomiting, anything as such?
Not that I remember.
Okay, no problem. Do you have any other specific body pain, maybe in your knee, in your ankles?
Pain? No. I do feel a bit scratchy in my elbow.
Okay, so you do have. a bit of some you have some itchiness. Do you have any
Yeah,
rash over there where you're itching?
I didn't check.
Okay, no problem. We'll take a look at that during the physical exam. Okay. Any significant past medical history? Do you have any chronic
No,
medical conditions,
not that I
asthma,
know.
diabetes, hepatitis? Nothing as such. Okay. Any past surgical history?
Yeah, I had my appendix removed when I was a kid.
Okay. The approximate year you don't remember?
I don't know, when I was maybe in ninth
Okay,
class.
fine, no problem. Um, are you taking any medications currently, or have you taken any medication to prevent these cramps and these stools from happening?
Uh, Prevent? No, just food remedies and all that. No medication.
Are you on any antibiotics?
No, I do use this cream for acne, but I don't know if it's antibiotic, whatever. Like just cream
Okay,
a doctor gave
okay,
me.
fair enough. What about your family history? Anyone with similar symptoms in your family?
Similar symptoms? No, I think my dad has hypertension, mom has blood pressure, and my dad also takes some medication in the morning, but I don't
Okay,
remember.
no problem. Um, your diet, it mainly consists of what?
It varies. I eat anything and everything.
Okay, do you think you usually end up eating more carbohydrates, or do you end up eating more proteinaceous meals? Any idea, or it's just random?
It is very random. A lot of time, like because of this feeling and this symptom, I don't feel like eating. So when I eat a lot. Otherwise, I don't feel like eating, so I don't eat at all.
Okay, fair enough. Any recent travel history?
Travel history. I've been to India 6 months ago, I guess. Yeah.
Okay. Apart from that, I would like to ask you any other questions or any other concerns that you have that you want to bring up with me.
Mm, no, not really.
Okay, just one final question. Do you smoke or drink?
I don't smoke. I don't drink.
Okay, you don't smoke and you don't drink. Okay. And I've already asked you, you have no further concerns or no further questions to ask me.
Not really. No.
Okay, fine. Thank you so much. We'll move to the physical examination part. Okay, so guys, that's the end of the history, right? I would just like to point out certain questions. So thank you so much, Neil. This was the first case simulation that we've had. I think it went pretty well. Vikram and Neil, do you guys think I missed something, or that I could have asked another question from what you guys observed?
No, I think it was a pretty extensive history. I think, you did a good
Okay,
job. I think you covered
yeah,
the main systems that you need to be worried about immediately.
yeah. Neil, what about you? During the interaction, was there something that you felt I should have asked?
No, I think it was pretty good. You asked questions I didn't even think of.
Okay. Regarding those questions, there were certain questions I asked that were very specific to the symptoms that he came with. The diet, a very important cause of indigestion and therefore diarrhea. But I need to keep in mind that this patient is facing these symptoms for a very long time. So it could be something chronic, right? Next thing, why did I ask about antibiotic exposure? Antibiotics are a very, very common cause of diarrhea. It's a very common cause that can lead to C. diff diarrhea or Clostridium difficile diarrhea, and therefore you can just treat it with oral vancomycin, no problem at all. And I also asked about travel history. I didn't ask about travel history because of the cough or pneumonia kind of symptoms. No, it's not that. It's because uh, when you have recent travel, E. coli from traveler's diarrhea is very common. It's too common, in fact. His diet being outside could point me towards giardiasis. Very, very common in developing countries having giardiasis. It's almost chronic in patients with indigestion. So it's very important to consider these things and therefore ask questions catered towards that sort of a diagnosis. Now you see, I have certain differentials in my head. I can go from autoimmune to anything. He also mentioned some associated symptoms like generalized body ache, but he also feels like he has backache. Now that backache could be maybe because of bone or maybe because of muscle. He mentioned that he just must have recently lifted a load. It could be a muscle spasm or it could be a long-acting bone problem, osteoporosis, osteopenia. Thinking of osteoporosis in such a young individual is rare. So I'm going to put it outside. Osteopenia, maybe there's a vitamin deficiency. A vitamin deficiency with some sort of diarrhea can point me towards an autoimmune condition like celiac disease. If you remember, he kept itching his arm. That was because he probably had some dermatological manifestation of celiac disease. So it's very important to get a holistic picture, a very comprehensive picture, and then have a list of differentials. From there, you will ask for your investigation after your physical examination, obviously, but from there only you will ask. So to me, overall, this points in the direction of something malabsorption related. So for me, it would be something like either celiac disease or maybe even Crohn's. Even Crohn's would be possible. So yeah, that's about it for this particular history. We have another case simulation in which Vikram's going to be the doctor and I'm going to be a bystander. So yeah, and Neil's still the patient. So please give it up for
Neil
Neil.
is still the patient, yes.
Yeah.
Pretty sick patient. Yeah,
Yes.
so guys, before we start, I just want you to remember we're going to do an emergency scenario here. Keep in mind primary survey, sample, exactly, very important, and the secondary survey, which we mostly won't be covering. Okay, hi sir, I'm Dr. Vikram and I'm your doctor in the emergency department. Can you tell me what's the issue?
Hello, doctor. Yeah, I was in office, but then I don't know. I don't remember. But my friend is telling me that I passed out and now we are in hospital. I don't
Okay,
remember how I ended up here.
so okay, you're saying you fainted. Okay, do you have any pain or any situation? Are you feeling anything as of now?
I feel weak, but no, nothing
You
more.
just feel weak as of now. Are you feeling any heart? Can you feel your heartbeat, or do you feel like you're hot or sweating?
I feel my heartbeat, sweaty a bit here.
Okay. Can I know your age, please?
I'm 24 years old.
24. Okay. And do you have any allergies to any medications that you may have taken before?
No, I just took my normal shot in the morning.
Okay. What medications are you? What shot is this?
I have diabetes, so I have this injection I have to take every morning. I think it's insulin.
Okay. Okay. So this is an injectable, right? And are you where are you using it exactly? On your thigh, on your shoulder,
I use it on
on
my
your
shoulder.
shoulder?
Yeah.
Okay. And any other chronic conditions that you have, or is it just diabetes?
No, just this.
Okay. And when did you eat last?
I had dinner last night.
Last night only. So you didn't have anything since last night, nothing in the morning.
No, I was too busy to go for work, like it was late, so I had to run.
Okay. And do you remember anything that happened before or after that?
Before, after what?
Before your fainting episode?
No, I don't even remember. I was just working in my office and all of a sudden I'm here now.
Okay. And do you have anybody with you who brought you
Yeah,
here?
yeah. My colleague Karthik is here with me. He also works in the office. He
Okay.
brought me here, I guess. Yeah.
Okay. And can you explain to me what happened?
So I just remember him calling out to me and saying, "I feel a little dizzy," and then he just fell. Like he just fell out from his chair. He was sitting and then he just fell out from his chair. So we all just
Okay.
panicked and came to
All
the
right.
hospital.
All right. Did you notice did he hit himself anywhere? Did he hit his head anywhere when he fell down?
So when he fell, since he called out to me, I did rush to him. So I at least prevented his head from hitting the ground with a lot of impact. But
Okay.
otherwise I don't think anything else was noticed. He just called out my name and he just fell on the ground.
Okay. And do you remember him having a seizure, having any jerky movements, say mumbling anything or anything coming out of his mouth?
No, no, doctor, nothing as such. He
You're
didn't
sure
hit.
you didn't see him having any jerky movements, any writhing, nothing. He just
No,
collapsed.
no, doctor. No, to the best of what I recall, I don't think so. There was no movement. He just fell. I just caught his head, thankfully, and that was it. We just we just
Okay. All right.
we just
Thank you. And I see you guys have come here in the ambulance. How long between him falling and the ambulance arriving? What was that gap?
between him falling and the ambulance arriving, I
Yes.
would say maybe about 5 to 6 minutes.
Okay. Okay. All right. Okay, so guys, thank you. Thank you, Karthik. Thank you, Neil. Thank you so much. So, guys, well, as you can see, just from sample alone, now I didn't go too much into primary survey because I'm talking to the patient. So that means the patient is alert, patient is okay. He doesn't have any complaints as of now. In an ideal emergency setting, by this time, the patient is already connected to the BP monitor, so you don't have to worry about that. And when the patient is talking to you without any problems, that means you can say that the patient is alert and he doesn't have any life-threatening conditions as of now. So I'll move on to sample. Sample, he said that he's fainted one episode. He said he's 24 years old. doesn't have any allergies, and the meds he was taking, he said he has a pump. Already you have a differential diagnosis, hypoglycemia, that can be, and he said he has diabetes. Most likely in a young patient, less than 40, 45 years old, you will think of type 1 diabetes mellitus, always. And considering the fact that he's taken his insulin shot in the morning, but he's not had food, there is almost just, you can narrow it down to hypoglycemia. Simple, just from sample. And he said his last oral intake was last night, and he had just had a fainting episode and no seizures. So you can rule out any neurological disorder, and you can just focus everything on hypoglycemia. Already within 5 minutes, you have a conclusion. You can go tell your doctor, I need IV fluids, I need IV dextrose 5% mg in 100 ml infusion with the IV fluids. Patient's going to be okay. Within 1 hour, he's going to be walking out of the emergency department. Simple as that. Now, the main thing you need to be able to take away from this scenario is that how sample was used, and making sure that you can go back and forth between primary survey sample and secondary survey. Now, for example, Neil himself, for example, while talking this, you see his hypertension drops. He's having hypertension, his blood pressure drops, and he faints. Immediately, you shift to C, A, B, C, D, E. You shift, you can, okay, remove C because he's not having catastrophic hemorrhage here, but you make sure his airway is patent, breathing, circulation. If you can't feel a pulse, CPR. So these are the kind of things you should be able, if the patient is stable, you should be able to talk and take a sample from him. But if he's not stable, you need to jump to C, A, B, C, D, E to make sure that, the patient might be in cardiac arrest, and you need to defib or you need to CPR immediately to make sure that you can save this patient's life. So immediately right now, you can go tell your doctor, yeah, doctor, hypoglycemic episode, patient fainted, I need IV fluids, I need IV dextrose. Patient's going to be completely fine. Within 1 hour, him and his friend can go back to work. So yeah, that was basically just the crux of it. Really hope you guys are able to take away something from this, and we will be coming up with more events and more webinars like this to help people understand how different life is from your textbook university life to an actual real life setting, because there was nobody to teach us these things, and we're just here to help you guys out. And also, this is like a recap for us. So thank you so much, Neil, for your patiently duties. Thank you so much for helping us. Thank you guys for giving us time. And also thank you, shout out to Ansika for helping us with the presentation. She did a lot of
Yes.
technical work. So yeah, Karthik, you can just close.
Yes. There are two questions
Okay.
on the Q&A. I will just go through them. And in case you guys, while I'm answering these questions, if you guys have any other questions, go ahead and put them up. We will definitely answer them right now, because I think we have about 20 minutes remaining, but we don't have any questions, and we can wrap up. Anyway, so the first question is, how do you fit in the questions in limited time? As in, how did you learn to fit it in? Since these questions usually take about 15 minutes and an OSCE is usually 7 minutes. Yes, good question. And see, there is a reason why you have a format, because let's say you follow that format, you know exactly the direction to go into. And well, if you ask the right number of questions, you can get your diagnosis as well. And usually that happens in 7 minutes. Now, the reason I understand why you say it takes 15 minutes is because at a university level, you might lack the experience. Once you've done this a number of times over and over again, you know exactly what to ask. There are certain questions you can even skip in certain patients. And this is very common. This is very common in clinical setup. It's just that because for the sake of the webinar, we're giving you everything, the exact flow in which you should be asking these questions. You're right. Usually you should fit within 7 minutes. But if you choose to ask certain questions that are not necessary, you will take more time. How do you know what's not necessary? By experience. So as much as you can, try to take patient histories. When you go back for your vacations, try to do observerships, try to take histories. That's all the tips that I can give you, honestly. I understand that, yeah, you have to listen to the patient. That is why you have to cut them short, which is why you give them the chance to speak in the beginning. You start with open questions, you have a field to ask your closed questions on, and then you take over the consultation. The patient will only speak for the first 1 minute, I feel, when you've asked them an open question. Yeah, Vikram, you want to add anything?
No, I feel like you've answered well. It just, for me, what happened was the first day I took history, I took about 20 minutes. And then as you take subsequent histories, as you go by every department doing your internship, you will understand the gist of how to take a history, what questions are very important in all departments, what questions are specific to one department. And you will just be able to wrap it up quickly. And like Karthik said, you'll be able to omit questions that you know are not needed. But for exam sake, OSCE sake, you will need to ask everything, and you just have to learn getting fast with it. And I'm sure in an OSCE setting, the patients won't unnecessarily talk, or they'll teach you how to cut a patient off respectfully. So you'll be able to stick to the time. But our goal was just to make sure that you guys are provided all the information, because when you start, you have to start with everything. And then with experience, you'll be able to cut it down, narrow it down to 5 to 10 minutes per patient.
Yes. So the next question is, will we be able to get this PPT or recording after the stream? So we're trying to put up the recording on a channel where everybody can see it. But what we can do is that maybe shortly after this webinar, maybe the next 1 or 2 days, we can just compile the points of the history for all 4 of them, and we can release a document with respect to that. So I think that will be helpful for everyone. Yeah. The next question is, in the ICE method, do we need verbal confirmation from the patient to ensure that they need drugs? Sometimes expectations from the patient can be understood because their body language or other cues suggest they want medication. This is a very, very good question. At least in my experience, I have used the ICE method only for concerns. As in, I have not directly asked the patient whether, well, what do they expect? What I've done rather is that, do you want tablet, or like, do you prefer tablet versus an injection? So if they say no to both, I kind of get the idea that they don't want medication, so I can go down that path. Obviously, when you're taking a history, you will conclude by saying, okay, I will speak to my consultant, or I will ask the nurse to start you on something. So then they can immediately, usually the patient itself will tell you that, no, I was hoping I can just get some tablets and go home. You have your question answered there, I think. Yeah, Vikram, you have anything else to add?
No, I think you've covered it.
Okay. So yeah, you're right. The body language is very, very important. You really need to understand. Sometimes patients just come in because, well, they just want to sick leave. It
See,
happens.
sorry, I'm very sorry to cut you
Yeah.
off, but I feel like
Good, good.
this specific thing, I feel like you will either way, as a job, as your role as an intern, take the history, but at the same time, when you go and report it to your doctor or to your consultant in charge, you will tell them also about the body, the behavior, and the body manner of the patient, and they will know exactly what to do. Like, you're not going to be prescribing your medications and all that, and they will then they will step in and they will talk to the patient, and they'll know if the patient requires it, the patient will get it. Patient, if they know that it's like malingering or something like that, and the patient's just gonna, the doctor's just gonna take care of it separately. Then you don't have to worry about that.
Yep.
But very nice question.
Yes. Question.
How to
The next
calculate
question is
EDD.
how to calculate EDD again. Yeah, Vikram, can you
Yeah,
please
I
repeat?
got this. So EDD, you take the patient's last menstrual period date. Okay, take the patient's LMP. It'll be one date. You deduct 3 months from it, exactly 3 months from it. So for example, if you're taking today, 26th, you would exactly deduct 3 months from it. Okay, you'll get a date. You add 1 week to that, or 7 days to that, and then you add a year, because obviously it's going to be 1 year later, correct? So you take the last menstrual period, you deduct 3 months from it, then you add 7 days to it, then you add 1 year. So the same time next year. That is your estimated delivery date. I hope I was able to answer your question.
Yes. Thank you. The next question is occupation and travel history not important in history taking? The travel history is, and we did mention that. Occupation, yes, you are absolutely right. We didn't mention that because a lot of the times patients don't present with diseases that, well, are concerned with their occupation, or usually if there is something occupational related, there is a doctor on site with respect to that particular occupation. But that being said, you are absolutely right. If you think that you should include it in your history, do go ahead and do that. It's not recommended, but I think it would add to, let's say you're in an examination, it would add to, well, the marks you would get, or the overall impression that you put even on your attending a consultant. So yeah, you can go ahead and do that. Yeah, that's a very good observation. Next question is, thank you for the insightful presentation. I was wondering if you have any tips on how you can gain the trust of a very shy patient. This is all clinical related. I mean,
Yeah,
I can just
I'll answer this.
yeah, go ahead, go ahead.
So how you gain tips from a very shy patient is, this can be with a child or with an adult. Okay. So what I feel is, usually when you have a patient who's not willing to talk, or they're shy, or they want to meet the doctor, they don't want to talk to an intern. One thing I learned from my doctor in emergencies, when you're going to meet, okay, I went to the emergency, and one of my friends, she was also in emergency, and the previous month, she went into the patient's room. She told that she was an intern and she's going to take history, and the patient said, "No, I don't want to talk to you." The doctor came back and said, "Don't ever tell anyone you're an intern. Technically, you are graduated, you are a doctor. Go to the patient, say, I'm your doctor. Okay, you don't have to say, I'm a junior doctor, I'm that. Say, I'm a doctor. There itself, you have the patient's trust a bit, because then they're going to be like, okay, I need to tell my doctor everything. I can't hide from them. Secondly, if it's a very shy patient, make sure that you take consent from the start. Like, say, okay, are you okay right now? Is there any concerns that you want to address right now? I'm going to be taking your history. Say, this mostly happens in the OB-GYN department. If it's a gynecological problem, you can say that I'm your doctor, I'm here to assess your problem and give you a management strategy so that everything goes smoothly. Can I go forward with this? Then they'll say yes or no. Mostly they'll say yes. If it's everything is very, basically you need to be cooperative and calm, keep a very normal demeanor, keep a very sympathetic demeanor. And once that happens, you don't jump into questions. Start, like Karthik mentioned, start with open-ended questions. Start with questions where the patient talks, because automatically so much you'll get there. And there itself, you can remove questions that you have in your head that you can ask, but the patient's already answered them. And then once that goes on, then you can move on to a little close-ended questions. And if it's a bit personal, you make sure you can ask them, okay, I need to ask you about this. Is it okay with you if I can ask you these, or you want me to bring someone else in? Or for example, if it's a female patient and you are a male taking history, what you can do is you can ask the patient, would it be better if you had a nurse here, or if you had another one of my female colleagues here, would you be more comfortable with that? Basically, you make sure that the patient is comfortable first, and then after that, you'll be able to go ahead with it. Even after all that, if they are not cooperative, that's just something you got to deal with and make. You can ask your female colleague to take the history, or you can just go report this to your doctor. But 99.9% of the times, the patients are cooperative, and if you ask everything smoothly and you're completely open from the start, it should go by smooth.
Right. Good answer. Good answer. Yes. I think it's pretty much covered regarding talking to well
Right.
a shy patient. Okay. Do you have any tips for remembering everything a patient tells you when taking their history? I mean, just follow the format. To be very honest, just follow the format and you'll remember it. Like follow Socrates, follow uh what after that? Drug history, family history, social history, medication history, past medical surgical history. Even if you mess up the order of the last four, at least you've covered everything.
I
So
believe
I
that
would,
if yes, go ahead, go ahead, go ahead.
no,
Go
I
ahead.
think just follow the format. That's all.
Yeah, I believe that this also comes with experience. When you
Yes.
are, because from first-hand experience, when you're taking a history, when they are telling you their story, you're building it up in your head as a story. Like it's very rare that you will forget something, because you are slowly building everything up in your head when you're listening to them. And you're going to be listening intently, of course, because you need to note it down, either mentally or on a piece of paper. You will get it with history, with experience. Don't worry about it.
Okay. So the next question is what to do if we miss some questions? Okay, this happens. This has happened to me personally in at least my first few months. It has happened. I think uh, there's the ICU consultant who told me once. He said, uh, "It's better to look stupid for the first 5 seconds in your first year rather than after that, because this is the year where you will learn." So honestly, if you feel like you've missed some questions, don't be shy. Go ahead and ask them again. Because at the end of the day, if that patient has spoken to you wholeheartedly and they've given you, that means they're consenting to give you that information. There's no problem in going back. I have seen proper consultants ask the registrars to go back and ask questions again and again and again. I have taken complete histories after a whole registrar has completed a full history taking. And I have found out some information that has been clinically important that the registrar might have missed. So I don't think it's a problem. I just feel like if you have remembered that you have forgotten something, do go back and collect that information, because even if it's not relevant, it's relevant for medical legal purposes when you document stuff. So yeah, that's just my experience. Yeah, Vikram, you want to add anything?
No, I think that was answered pretty well.
Okay. Yes. Next question. When would you ask about pets in history taking? Would that be if there is a pulmonary problem or any allergy, or would you put pets under accommodation? I mean, the social history of accommodation. What do you think, Vikram?
I would see if the patient is coming with a pulmonary problem, especially allergies, stuff like that. You definitely need to ask about pets, because this is very common in completely developed countries as well, where you can have a lot of diseases or a lot of pathologies that can stem from domesticated animals. So I feel like if you have the time for it, and for example, if the patient is coming with chest pain or like a headache, or a stroke patient or anything, UTI patient, you don't need to ask about pets. It's usually not going to be related. But if you want to be on the safer side, you should ask about pets. Make sure if you're going for an OSCE, you definitely need to ask. When you have to do these things, you have to do it. But as you get experience, you'll know which systems are related with what, and you can rule it out. But to be on the safer side and to learn everything from the starting as a whole, it's better to ask about any pets. It's just one question. It's a yes or no question. So why not?
Yeah, true. I think so too. Usually I've asked about pets in a pediatric history taking, or if an adult patient has come in with a new onset like sinusitis or rhinitis kind of symptoms. That's when I usually ask. Because if they've had this pet for a long time and they've suddenly come for something, there has to be something that's changed. So only then I would ask about this kind of a symptom. Or then if this has been going on for so long and there is no visible trigger identified, then I would tend to ask about pets. But otherwise, I don't think so. But if you can, go ahead and ask it. Believe me, no question is a wrong question, as long as the patient consents to answering it. That's what's important. Uh, this is a very nice question. What are the potential biases that can affect history taking, and how do you mitigate them? How do you ensure that these biases do not influence the accuracy of the patient's history? I think I should just copy paste this thing into chat GPT. Maybe it can give you an answer regarding this. I don't know what biases are you expecting when it comes to history taking, but I can tell you that if you think of a bias, that means you're not doing your job well at taking that particular history. Regarding the accuracy of the patient's history, again, see, if you want to not trust the patient, then you made a mistake there itself. You have to trust the patient. Whatever the patient says has to be written down, it has to be documented, it has to be communicated with the specialist or consultant, and based on that, only your therapy works. So, I mean, the accuracy of the patient's history is completely on the honor code. You trust them, they are here because they trust you, and ultimately you act on it.
The
Uh,
patient has no reason to lie, so I think it should be
Yeah, the
fine.
patient has no reason to lie exactly, unless they have like some psychiatric condition, like some
Yeah.
Munchausen syndrome. That's a different conversation. But yeah, otherwise, I don't think so. But yeah, I think you can get better answers if they can put that question into Chat GPT. Maybe it can give them some insight. So yeah, I think we're done with all the questions. I think Vikram, is there anything else you'd like to add to the webinar so far?
Nope. I hope you guys took away as much knowledge. I know there's a lot of things that you guys have gotten, a lot of information that was given out. I hope that you guys were able to take the main gist of it. We'll try our best to put up this recording of this meeting on a platform. I think it might be YouTube, some other platform. We'll let you guys know. And I hope you guys can take up the information from there. Apart from that, no, I hope you guys had fun. Thank you for spending your Sundays here. And yeah, I hope we can have more events like this. And you guys should be looking forward to more alumni events. Hopefully, we'll have some coming out. And it will be ones that will definitely help you guys. So spread the message.
Yes. Thank you, everyone. Thank you for joining. All the very best